spike. Just remember these cute little postprandial birds nibbling away the initial peak of this gingerbread house. Next, the intermediate acting insulin agents, regular insulin and neutral protamine Hagedorn, or NPH. Their names represented by the rest now sign. First, notice the peak at this section of the gingerbread house is more delayed. When given subcutaneously, regular insulin starts working within 30 minutes, peaking in 2 to 4 hours. The more delayed onset of action of regular insulin is due to the formation of dimers and hexamers. These take time to dissociate after injection, causing some absorption delay. This makes regular insulin less useful for controlling that rapid postprandial glucose spike. However, regular insulin is the only type of insulin that can be administered IV for special situations. Hence, our recurring ubiquitous IV. When prepared for IV injection, the dilution of hexameric regular insulin immediately dissociates into monomers. It therefore has a rapid onset of action, particularly useful in the management of diabetic ketoacidosis. Diabetic ketoacidosis is a medical emergency caused by inadequate or absent insulin replacement. So all the glucose builds up in the serum, locked out of the tissues because insulin isn't there to bring it in. Your body becomes starved for glucose, so your liver starts to release ketones, an alternate energy source for your brain. This combination of elevated serum glucose with elevated serum ketones is depicted by this high glucose candy cane key. Think diabetic ketoacidosis when that 21-year-old presents to your emergency department after several days of dizziness, vomiting, fatigue. He's been drinking a lot and he's been peeing a lot. You check his urine and bingo, you see glucose and ketones. That patient's vomiting and dehydration, along with glucose and ketones in the urine, are consistent with diabetic ketoacidosis, or DKA. What's next? Well, along with starting IV fluids, let's get that glucose into his cells. IV regular insulin is your agent of choice here, lowering serum glucose and ketone levels within minutes of administration. Sub-Q insulin should not be used in these patients because it's harder to control, and they're usually severely volume depleted, so absorption under the skin won't work very well. See this other strand of IV heading toward the consumed potassium banana? While you're loading this patient up with IV insulin, remember that you're also driving potassium into cells, leading to hypokalemia. So get some potassium ready to replete that falling serum potassium concentration. This effect, however, can come in handy when you're trying to treat hyperkalemia. IV insulin can be used to rapidly bring that serum potassium down. Remember, you're driving glucose into the cells as well. To avoid hypoglycemia, insulin is delivered along with glucose. All right, all this talk about regular insulin. What about NPH, the other half of the rest now sign? Well, the action of NPH is more unpredictable, so it's not used as much clinically. Just remember that it's an intermediate acting insulin with delayed absorption and an onset of action within 2 hours. Okay, let's move on to the long-acting insulins, insulin detamir and glargine. Their names are represented by the don't go sign. Notice that the roof at this section of the gingerbread house is long and flat. When given as a regular daily regimen, long-acting insulins provide a long, steady basal level of insulin. You see, diabetic patients often need 2 types of insulin, a postprandial short-acting insulin to control glucose spikes after eating, and a basal long-acting insulin for that constant background insulin activity throughout the day. The best basal long-acting insulins are glargine and detamir insulin, administered as shots 1 to 2 times daily. Glargine is the longest acting, lasting for about 24 hours without a distinct peak. Because you're driving all this glucose into cells, hypoglycemic reactions are the most common complication of insulin therapy. In this sketch, whenever we want to emphasize that an agent has increased risk of causing hypoglycemia, we'll include these red, overly ripe glucose candies falling off the tree, kind of like falling serum glucose levels. Hypoglycemia can cause signs of autonomic hyperactivity, both sympathetic, such as tachycardia, palpitations, sweating, and parasympathetic, such as nausea and hunger. It may even progress to convulsions and coma if untreated. Glucose can be given by mouth, or in a stuporous or comatose patient, glucose can be given IV. An intramuscular glucagon injection also works well. Just remember, glucagon for when your glucose is gone. Alright, as the sulfonylurea swan enters the scene to warn the kids of this witch lady's ulterior motives, we're going to shift focus a bit. Exogenous insulin administration involves the agents we've just discussed. It's essential to the management of type 1 diabetes. That's because in this condition, you can't make insulin. Type 1 diabetes mellitus usually results from autoimmune destruction of the insulin-producing beta cells in the islets of Langerhans. So you need to give them insulin exogenously. Now, type 2 diabetes is usually characterized by insulin resistance. In other words, in the early stages of the disease, your pancreas can make its own insulin. Your body's just resistant to it. As type 2 diabetes progresses, beta cells start to fail, and many patients will also be on an exogenous insulin regimen. However, while there are still functional pancreatic beta cells around, there are a few ways to give them an extra boost and upregulate your body's own insulin. One class of agents that does this is the sulfonylureas, represented by the sulfonylurea swan, of course. Also, to help you remember that we're talking sulfonylureas here, we've included our recurring symbol for sulfa drugs, some stinky sulfa-ridden swan eggs. While insulin is injected, these agents are taken orally to stimulate endogenous insulin release from beta cells. Remember, for endogenous insulin release to occur, ATP-dependent potassium gates need to close. Well, sulfonylurea works the same way, by binding the potassium channel, shutting it off. And that's why this sulfonylurea swan is behind that closed potassium gate. This leads to the normal sequence of events. The beta cell depolarizes, calcium rushes in, and the beta cell releases endogenous insulin. Keep in mind that whenever we're stimulating normal insulin release, those C-peptide candy wrappers get released as well. So you will measure increased C-peptide in the serum with these agents. Okay, I just want to briefly run through the specific generations of sulfonylurea agents so that you recognize them on the exam. The first generation includes tolbutamide and chlorpropamide. They both have that "mide" suffix, so we've given our sulfonylurea swan a maid outfit. These first generation agents have to be given in larger doses, and you won't see them on the exam as much. Second generation sulfonylureas are way more potent and are administered in smaller doses. These agents include gliburide, glimepiride, and glipizide. When you think of these second generation agents, gliburide and glimepiride, think of these second generation goslings riding on the back of Mother Goose here. Wait, is this a swan or a goose? You know, I never could tell the difference. Glipizide is the shortest half-life of the more potent second generation agents. Think of glipizide as this glipizide gosling making some Z's in the water as he zigzags along beside his mom. The meglitinides are another class of oral anti-diabetic agents, similar to the sulfonylureas. The meglitinides include repaglinide and nataglinide. To help you remember that glinide suffix, just think of this Father Goose gliding into the scene. Meglitinides are short-acting glucose-lowering medications with a mechanism of action very similar to the sulfonylurea agents below. In other words, they bind potassium channels, shutting them off, leading to depolarization of the beta cell, calcium influx, and release of insulin. This is endogenous insulin production we're talking about here, so remember that C-peptide is released as well. Also remember, this is a Father Goose, so no laying those stinky sulfa eggs. Repaglinide and nataglinide are not sulfa drugs and can be used in patients who experience an allergy with the sulfonylureas. Because of their ability to increase endogenous insulin release, regardless of blood glucose concentration, both sulfonylureas and meglitinides carry a significant risk of hypoglycemia. Just like with those insulin analogs, we're going to represent this increased risk of developing hypoglycemia with these red, overly ripe glucose candies falling off the tree, kind of like falling serum glucose levels. Hypoglycemia is more common with long-acting sulfonylureas and in elderly patients. Because we're releasing endogenous insulin here, remember that activation of insulin receptor does not only facilitate glucose uptake. Insulin jumpstarts a number of anabolic processes inside the cell. This includes storage of triglycerides into adipocytes. Hence, another adverse effect of